From Redox and Healthcare Strategy Bullpen, welcome to Diagnosing Health Tech.
Thank you and good morning. I'm Jeff Englander. I'm the founder and principal of Healthcare Strategy Bullpen, and I want to welcome you to the show this morning. It is my pleasure to actually welcome our producer, David Millsaps, who is our co-host this morning. It's kind of like pulling back the curtain in The Wizard of Oz and seeing the person behind the curtain. So welcome, David.
Oh, thank you so much, Jeff. It's so nice to be on this side of the camera today. So I've been producing all the Diagnosing Health Tech shows, and I run the brand and growth group here at in the Redox marketing department. But today I'm so excited to have Sherry with us and to talk about the economics of Medicare. It's going to be awesome. So thank you for having me, and very excited about today's show.
Well, thank you, David. It's my pleasure to introduce Sherry Glied. Sherry is the Dean of the Robert Wagner School of Public Service at NYU. And just in the interest of full transparency, I'm actually an adjunct at Wagner, which is part of how this came about. Prior to being at Wagner from 1989 to 2013, Sherry was at the Mailman School of Public Health, where she was a professor of health policy and management. Prior to that, from July 2010 to August 2012, she was the Assistant Secretary for Planning and Evaluation at the Department of Health and Human Services. Her principal area of research are in health policy reform and mental health. And Sherry has a BA in economics from Yale, an MA in economics from the University of Toronto, and a PhD in economics from Harvard. So three of my favorite places, Sherry: Connecticut, Toronto, and Boston. All of them all wrapped up. So welcome.
Thank you so much.
So Sherry, part of the genesis of this was the article in the New York Times that talked about the shortfall, so to speak, from budget predictions of Medicare spending of about $4 trillion between 2011 and 2022. And I'm wondering if you can talk about some of the factors that appear to have gone into that, and why that may have occurred.
Great, thanks, Jeff. So I should actually start off with a shout out to the CMS actuaries, who have a completely impossible job, right? They're supposed to predict each year what the Medicare spending is going to look like for the next 10, actually for the next 75 years, which is insane. One of the things we tried to do when I was at HHS is shorten that window, because I can't even think of what it means to predict what Medicare is going to look like 75 years from now. But let's just focus on the shorter term, which is the forecast you were talking about. So the actuaries try to figure out what's going to happen, and basically what's going to happen is a function of more or less three and a half things. One is what's going to happen to the population. How many people will be on Medicare in the future? And that is, relatively speaking, not that difficult a problem. The Social Security actuaries have to do the same thing. Sometimes you have events like COVID where there's excess mortality among elders, and that's going to change the forecast. But that's not, that did not show up in the 2019 numbers that the New York Times was referring to. So there's the demographic piece. How many people will be on Medicare? And then there is how much use will each of those people, how much use of the system will each of those people have? That's a function of, do people go to the doctor or not? And it's also a function of kind of what are the technologies that are available to them? What are the drugs? What are the other things that are available, which will lead to whether people actually seek care? And then the third element of this is, what are the prices that are paid for care? For the most part, the prices that are paid for care in the Medicare program are enshrined in statute. There are formulas that determine how those prices change over time. In 2010, there was a big change in those formulas in the Affordable Care Act, but the stream of those prices over time is known for given technologies. Okay, so now why could this forecast go wrong? What might go awry? The biggest challenge I think that the actuaries have is forecasting what the technologies and the use of those technologies is going to be over the next 10 years. So if you look at the factors that have led to the growth in healthcare spending over time, economists are pretty much unanimous in believing that the main force that's been leading to healthcare cost growth has been the introduction of new technologies. And that's what the CMS actuaries are kind of predicting. But if the introduction of technology slows down for whatever reason, or the pricing of new technologies is different than the actuaries expect, then that's when those forecasts can be quite a bit off. And that's really what we've seen here as well. So let me stop there because I just talked for a long time, and I know that's a good thing.
No, that's very helpful. So, part of that is, there was, earlier in the period, there were statins, so there hadn't been any tremendous new blockbuster drugs in the period we were talking about. Some of the, technologies that you were talking about, no huge technological development. Now, last couple of years, we're looking at the GLP-1s. We're looking at the advent suddenly of AI in healthcare, which may actually drive down the cost a little bit. So given, at least forget AI for right now, because that may be a little bit on the cusp, but the GLP-1s and the huge cost, where do you see Medicare spending, going, and what do you see adding into that?
So I should say that even during the period that the 2010 to 2019 period, that was the period that where the new Hep C drugs were introduced that were really expensive, right? So it's not like we do have these and many other very, very costly drugs were introduced during that period. So we do have precedent for the introduction of drugs. The real question is sort of the pace and breadth of use of those drugs that are introduced. So the Hep C drugs had the fortunate feature that they actually cured the disease and there was a limited number of people who needed them. The new semaglutide drugs, that's not true, right? There's loads and loads of people, and you probably have to take the drugs forever. So it's maybe more similar to statins than to the Hep C drugs. On the other hand, right, there are lots of competitors in that market already. For the moment, the drug needs to be injected, which is not something people like. And people are a little bit, we're seeing a big uptick right now. How far that will go up, I think, as long as it requires injection, I think that is probably a limiting factor. But it won't forever require injection, and people will want to use it more. And then I think the question becomes, to what extent can CMS manage the competition among the substitutes that are already in the marketplace in terms of what happens to the price of those drugs? And also, to what extent does the use of those drugs reduce subsequent hospitalization costs? So the Medicare program has, in that sense, kind of, the kind of benefit that if you can actually make people healthier, that will redound to the benefit of the Medicare program. It's not a great value proposition for private insurers, because usually when people get healthier, it's after they're already on Medicare, but it does help Medicare.
So where would you see, so would you see a continuation of this pace of, spending maybe falling a little bit short of expectations, or are there other factors coming into play? I know we had talked about the IRA and things like that.
So, I think so first of all, the challenge here is figuring out what the actuaries' expectations, how they update their expectations. So I'm not going to make any assumptions about what they're going to do. They will make some assumption about what happens with these drugs. But we do see there are some changes that are already in law as well. Okay, so let me go back to my story, right? There's a utilization factor, there's the new technologies that are developed, but there's also the question of how much we pay for those technologies. There's the pricing piece of this. And a lot of the legislative action that slows or grows Medicare costs has to do with the pricing. So, for example, the IRA talks about negotiating prices for very costly Medicare drugs, and that should generate savings in the Medicare program. It could even, not in a good way, or maybe in a good way, there's a lot of debate about this, slow the growth of technological development in the costly drug space. And that would have an effect on both outcomes and costs. And there's just huge debate about that. I should also say, just going back to the Medicare question, one of the things that happened in 2010 is that formula for updating prices in the Medicare program changed quite substantially, particularly on the hospital side. And under the Affordable Care Act, hospitals are expected to generate annual productivity improvements in the same way that the rest of the economy kind of is anticipated to do that. And that actually was a pretty big hit, permanent hit to the rate of growth of hospital prices. And again, that might have knock-on effects in terms of the willingness of hospitals to invest in expensive new technologies that are not necessarily going to pay off under a revised pricing structure.
Right. David?
Yeah, well, I guess I'm curious if there's precedent for price controls limiting R&D, like what you were just speaking about. Is there precedent for that in the recent past?
So there is a lot of literature. We haven't had price controls in the US, so we can't really say whether they have in the past limited R&D, but there's an economics literature trying to assess whether, for example, expansions of health insurance or growth in certain population subgroups led to more innovation in the drug space around them. So if the market grows, do we see more drug innovation? So you sort of have to have, there are two stories of drug innovation you want to keep in your head. One is the scientific story of drug innovation. You know, you leave the piece of bread in the petri dish, and in the morning there's green mold on it, and it's great, and it's penicillin, and it saves everyone's life, right? So that's kind of a bottom-up, science-driven model of drug innovation where, you know, things get invented. And then there's the second side of it, which is, so what do you take off the shelf? There's a lot of mold growing. Which pieces of mold do you actually take to market? And there's no question, I don't think anyone would disagree, that whether pharmaceutical companies take something to market or not is a function of how big they think the market will be. And maybe the best example of that is the mRNA vaccines, right? They were sitting on mRNA vaccines. They already had mRNA vaccines, but there was no market for them. So it wasn't really until COVID came along that anybody bothered to actually commercialize those vaccines. It wasn't that somebody woke up in February of 2020 and invented the mRNA vaccine. There's no way that would have been possible, but there were examples of it. They had already gone through quite a bit of the process before COVID came along, and they were able to do it. So I think there is this question of, you know, what things will drug companies take off the shelf in response to a bigger market? And the debate among economists here. So there are a number of studies that say, yes, there is evidence that the size of the market affects how much gets taken off the shelf. And that's CBO incorporated that in their estimates of the IRA, for example. The big debate is, how useful are the things that are not taken off the shelf? So is the stuff that gets left on the shelf the things that are, you know, cures for important diseases, or the things that are left on the shelf the 14th iteration of something or other, or, you know, the Me Too drug, or the drug for something that it's not a very effective drug, there's just a pretty small market for it, and you're tweaking it there. I think the latest research suggests that a lot of what is stymied by cutting the market down marginally, as would be the case here, is not the big, great stuff, but is sort of the less important things.
Sherry, following up on that, you know, part of the research I read is that some of the companies are going to wait to see not just kind of the follow-on patent extending, uses, but, you know, are there true second indications and the size of those markets, and that could impact funding in, you know, biotech and even in maybe some of the rare disease space. Any thoughts on, you know, because of the size?
Right. So I think the first thing to note is that these price controls are only on a pretty small, you know, a piece of the U.S. market, and they're fairly limited in their scope. So I think, you know, this is not going to lead to a full-on collapse of the pharmaceutical industry. I don't think that's a realistic point here. On the other hand, the marginal returns to pharmaceuticals surely will drop a little bit because you're putting some price restraint on them. That's almost mathematically true, right? And you have to ask the question, well, how do we think? So do we think the number is right at this moment? So let me turn the question around for you, Jeff, right? We know that right now, the thing that drives the pharmaceutical market is the patent, right? And the length of the patent period. We could actually make patent periods longer, and that would make the market even bigger, and there would be more drug innovation. Would that be a good thing to do? We don't, you know, there is, it's not always, there's not the optimal level of drug innovation is not something I think anyone has actually calculated. But whether we are above or below that level, I don't think we know.
Right. Would you go ahead, David? I think you had a follow-up question.
Well, we're talking a lot about drugs, and you spoke about the efficiency requirement of the Affordable Care Act. What are the other major levers in this space that are kind of relevant for policymakers?
So, productivity improvement in the economy is something that is largely invisible. Little changes that happen all the time in all sorts of places. You probably, if you thought really hard about your role as a producer on this podcast, there are probably things you've done over the past year that improve the productivity of your staff. You change the filing system on the folders or whatever, and that is a productivity that generates productivity improvement. So to some extent, I think the idea here was we are overpaying. We are paying more every year for the way the Medicare hospital formula works. I'm not being really clear here. Is it's based on the cost of inputs. How much does the cost of inputs rise? And the idea here is over time you should be able to do the same with a little bit less input if you have productivity improvements. And we're probably overpaying you in the sense that you are achieving those productivity improvements, but we're not capturing them in the pricing. We don't really, right? So that's the intuition here. Now, if you think about what's going on in AI, in the computing and in the cloud and so on, healthcare is an information game. That's what it is, more than anything else. It's about information, and the cost of dealing with information and the productivity improvements we've been able to achieve everywhere around information have been huge. That's where the productivity improvements are coming. And so I think there's lots of scope for more, and that we should be seeing more.
Now, there's a lot of thought that some of the productivity improvements in healthcare with AI, particularly for hospitals, are going to come at so-called the front end in terms of billing, procedures, supply chain. How much does that help the cost formula? And is that kind of what you've heard? And would you agree that it's a little, the sense is if it comes to clinical and helps some of the clinical productivity later, that may not be as important or may not impact the costs as much?
I think the natural place to go first is all on the administrative function, because the administrative function in hospitals is not that different than the administrative function of many other things. So there's a lot of it's not off the shelf. Nothing in healthcare is off the shelf, but we have a good notion of how to do that, how to think about supply chain and how to think about productivity improvement in administration. And remember, these are enormous companies with huge numbers of employees and very large amounts of billing and administration. There's a lot of savings to be had there. There's also potentially savings to be had around nursing care, in the sense of optimally, coming up with when people need to get different kinds of interventions within the hospital. I have no idea, right? But we shouldn't neglect the idea that there will be improvements even there, even in scheduling. I don't know. Machine learning might be able to tell us how better to schedule the operating rooms. I don't think we've exhausted by any means the scope of these technologies to generate productivity improvement. Of course, that productivity improvement has implications because the number of people who need to be treated doesn't change a huge amount when the price drops, right? So if we think about sort of the demand for hospital care, if we get a lot of productivity improvement and we are able to reduce the price of hospital care, just imagine, or relatively reduce the price of hospital care, it's not like there are going to be that many more people who are going to show up at hospitals. It may mean we need fewer hospitals. So that's going to be quite a seismic change if that happens.
Right. David?
Well, I guess that kind of makes me, one of the things that when I was preparing for the show, I watched your presentation, Why Your Broken Rib Costs an Arm and a Leg. And that was very focused on administration and sort of how the incentives were to improve, or, they basically built an incentive to do more administration or kind of bend the sort of maybe not, I don't know how to describe it, but basically you were kind of increasing administration because that was what increased profit in this. And I guess with that, just now you were talking about sort of the demand elasticity. How much was that elasticity a factor across this shortfall? Were people deferring care during COVID? I mean, I know personally I was deferring care in early COVID. So I wonder if that was just if we're going to have some kind of increased burden outside of the window.
Great question. Excellent question. So first of all, I think the numbers that Jeff was referring to actually end in 2019 for that reason, because the COVID time was very complicated. And in fact, the way CMS, the way the actuaries dealt with the cost of COVID is that they counted the very, very large amounts that CMS provided to healthcare providers to offset the reductions in care that happened during COVID as part of national health expenditures. So the fact that we propped up the hospitals and everything meant that national health expenditures did not fall, even though no one was getting any care. It was an accounting thing. It just moved from one ledger to another. There are literally thousands of health services researchers and epidemiologists trying to figure out whether the reductions in care that we had during COVID were good or bad or in between, or which ones were better. And I'll just tell you, one of my students did some work on this, and I think it's really illuminating. Which she was looking at women who were pregnant during COVID and what happened to deliveries. And there's a lot of literature about this. And one of the things that she finds is that some kinds of emergency deliveries, like C-sections and things like that, went down because people were not getting as much testing before they delivered, which is kind of an interesting, right? So I don't know, was that good or bad? I'll let her figure out what happened to the babies and the moms, but we do a lot of things, and we might cut down on some of those. There's a great paper by Bapu Jana. I don't know if you've had him on the show yet, but if you haven't, he does Freakonomics. He's the healthcare Freakonomics guy at Harvard, and he has this great paper showing that on the days where there are the big national cardiology conferences, cardiac mortality drops.
Mm-hmm. Mm-hmm.
That's super interesting. So I will follow up with you on that, Sherry. Here's a question that a little bit different for someone who has followed healthcare and healthcare policy. How would you advise principally senior leaders in providers and payers, what to look at, what to watch, who to follow? Would it be inside health policy? Would it be, CMS, obviously CMS, but would it be certain publications of CMS? Where would you look? What would you tell them to keep an eye on? I'm sure they all have armies of lawyers and lobbyists.
They have armies of people, and I don't know whether I want to pitch one health policy journal over another. Kaiser puts out a very nice daily newsletter that summarizes kind of some of the big policy innovations in healthcare. That's always good to look at. They do a health news summary, which is useful. But CMS regulations will be provider type by provider type, and so people are quite adept. I think the people who are in hospitals know about what's going on in hospitals, and the people who are doing drugs know about what's going on in drugs. I think it's also important to look at some of the broader sources, because although you might think that as a hospital, what's happening in drugs doesn't matter to you, it really does. Like if payment policy and regulatory policy make the availability of these anti-obesity drugs bigger, you may have fewer hospitalizations for diabetes or 3 or 4 years down the road, and you need to think about that. I was just talking to Tim Ferriss, who not the management guru, but the guy from Massachusetts General, who just came back from running the National Health Service's digital transformation project for the last 2 years. And he's talking about new multivalent vaccines that are going to be available pretty soon. You'll get one shot for COVID, RSV, and flu. That will actually substantially, if people take it up, substantially reduce the burden of respiratory illness in the wintertime. That will actually cut down on hospital occupancy in the wintertime, free up space for surgeries and other things. So overloaded operating rooms will have the opportunity to be doing more operations because there's space on the wards, in the recovery to take care of people. So I think you as a health policy person, one tends to focus as a health, a manager, a payer, or a provider. You tend to work very much in your own space. But I think it's really important to realize that these spaces are highly contingent on one another. So changes in nursing home policy, which seem like they're in a totally different space, affect the availability of skilled nursing facility slots and the ability of hospitals to discharge their patients from the hospital, which means that affects how many beds are available, which affects the way emergency departments work, which affects whether you want to go to your primary care doctor. So everything is interconnected in healthcare.
Yeah. David?
Well, I guess just like this is more of a general question. I want to stay on theme, but I'm so interested in the way that you're talking about the system as a whole and this sort of systems analysis and how an economist looks at it. And I think I wonder, our audience is healthcare leaders and then technology developers and things like that, folks like that. What kinds of you have a career of doing this type of analysis and looking at these systems and cause and effect. What kinds of tips do you have for us mere mortals for trying to do the same kinds of assessments around healthcare? Very interesting.
I think once in a while, not all the time, most of the time we should all just do our jobs, and that's good. But you should set yourself up a day or something. You need like a long walk, a very long walk after listening to a couple of these podcasts, and think to yourself, okay, let's start with the patient, because at the end of the day, that's what this is, right? The consumer is a patient at some point. What is it that they actually want here? And how does the thing I'm doing play into that? And how do all of the other changes that are coming along affect that person? And then that's the beginning of the causal chain, right? Don't start with how does this affect the nursing home or whatever. Start with how does this affect the person? What is this going to do to them? And then let's just walk through all of the gears in that complicated machine. Which patients. So one of the things I'm worried about right now, okay, we've got these new semaglutide drugs and they seem to be really effective. But they're going to be expensive and they're going to require follow-up. And I mean, we're a ways from the moment that they go in the drinking water, right? So people are going to take them. So what happens to people who lose their insurance or are churning from one kind of coverage to another? What happens if you live in one of those states in the South that hasn't expanded Medicaid? So you have really low income, you're getting these drugs, and then you lose your Medicaid because you get a job, and now you can't get the drugs anymore. Your weight is going to go back up. You're actually worse off than you were perhaps beforehand, right? Should we not put people on those drugs in the first place if we know that's likely to happen? We do that actually with, we think about transplant patients. If they won't be able to continue taking their anti-rejection drugs for whatever reason, that drops them on, are we going to start thinking about that same problem here? Or what about people who can't make it to the doctor to get injections of these drugs because they work a job that doesn't give them sick leave? Or, you want to think about how is this going to affect the people who are in this space? And how do I develop technologies that actually address them where they are as opposed to where I'd like them to be?
Mm-hmm. Following up on that, Sherry, as you think about, disparities and health equity, there's a big move now for the FDA to incorporate more real world evidence in the clinical trial process, in drug development, and in everything they're doing. Are there ways in Medicare where you see actions on disparities being taken that could help the delivery of Medicare and even Medicaid?
So I think the CMS is really concerned about disparities, and they're trying to do work on this right now. It mostly seems to be around measuring people whether people have food insecurity or whatever in hospitals. I don't think that they've gone. I don't know that people have thought through particular use cases, which is kind of where I would want to go here. So one of the things that we know about disparities, or one of the things I know about disparities, I'm not sure everybody agrees with me on this, but I'm going to put my stake in the ground, is that develop new knowledge and technological development tends to increase disparities. That's a terrible thing to say, but more educated people are more open to science. They are more interested in science. They follow it. They know people who are using it. They know where to go to get care. And they're going to be the first people to take up, within the class of people who benefit from a drug, you're going to see the greatest uptake of it being among people who are more educated. I don't think the answer to that is to say at the FDA process, well, we don't want to approve this drug because it's going to increase disparities. I think the answer to this in the FDA process is to say, well, what do you do in the design of the drug? How do you make it easier? Or what do you have to fund as an ancillary service with it to make it possible for this drug to get its the best effect it can on different kinds of people. So if the concern, I just made up this concern, right? Lots of Americans don't have paid sick leave. If people can't get to the doctor to get these injections, what can Medicaid do? What can Medicare do to make sure that there are doctor's appointments available, that there are or nurse practitioners or whatever it is you're going to do to deliver things outside of the normal scope of business hours, because it's going to be more important than ever. I just made that up on the spur of the moment, and right. I don't mean that as a policy. But we should be thinking through not just what does it do. I mean, I congratulate the FDA for thinking about how does this stuff work in the real world, but I also think we want to be pushing developers to say, and how do I fix that? How do I make it work better in the real world? And I should say, I mean, one of the fields I work in a lot is mental health policy. And mental health is a very frustrating area because there's been so little drug development and it's not been tremendously successful. But I started working in this area when Prozac was approved, when Prozac came out. And before Prozac came out, people who worked on mental health spent all their time agonizing over the fact that primary care doctors didn't ask anybody about depression, and they didn't do anything about depression. And then Prozac came out, and all of a sudden, primary care doctors began to ask people about depression. But what had happened? It wasn't because of a marketing campaign or anything like that. It's because the doctor has, if we think about going back to the consumer or the doctor, right? Like go back to the agent who's making decisions here. Doctors, what's the point of asking somebody if they're depressed if there's nothing you think you can do about it?
Right. So let me ask one more, and then David, I'll let you ask the final question. So Sherry, as we just had the IRA, obviously Medicare pricing in that, a little bit of a tough question because we're in an election year, but do you see any areas, maybe where there's somewhat bipartisan support in action on Medicare going forward?
I have not seen a lot of really creative thinking about Medicare going forward from either group. It's kind of interesting. Back in the 2000s, there was a lot of interest in moving to a Medicare Advantage for all kind of system. I think some of the air has come out of that balloon. I think people are less excited about it than they used to be. I don't hear as much about it as I used to hear. In the meantime, we have this huge problem in Medicare. We haven't talked about it, but it's a huge problem, which is that the way that we price Medicare Advantage just doesn't work anymore. It's not because of risk adjustment or any of that. It's just like if your market's got 85% Medicare Advantage and you're pricing Medicare Advantage off the fee-for-service market, that is completely illogical. It doesn't work, right? And both Republicans and Democrats have got to agree on that. We need a system to pay for these plans, and it can't be based on the 15% of people who stick it out in Medicare fee-for-service, because they're not typical of anything, right? That's just a bad group to be basing pricing off of. So what are we going to do?
Would you go and we had Tom Scully on, as I think we talked about about that a little bit, and Tom and I were talking offline. Would you go to an auction, or what could you do? Because you're fast. I think you're over 50% in every county in the nation, and I think as a nation as a whole, we're now over 50% for Medicare Advantage. Would you go to some kind of an auction pricing, or what could you do?
I think the challenge with an auction pricing is that you can't really force consumers into plans. I guess you could have auction pricing and have 5 plans win the auction, or there are lots of challenges. I mean, I haven't seen a perfect solution to this. There won't be a perfect solution to this. I haven't seen a perfect solution to this, and I worry. And one worries a lot about the risk selection in the Medicare Advantage programs as well. So the challenge with auction pricing is you don't want the winner of the auction to be the person who is the best at screening out the sick people.
Yeah. David, I will let you go ahead and wrap up with the last question.
Sure. So from your vantage, what would be your recommendations to providers who are preparing for some of these potential changes, and how can they best be positioned to kind of serve this market as it's evolving as Medicare Advantage evolves?
So, I mean, I think the advantage of being nimble and agile just gets bigger and bigger over time, and not locking yourself in too much to a particular way of doing things, but recognizing that things are changing, because the pace of change in healthcare, both from the technological perspective and I think eventually from the regulatory perspective, is, if anything, only going to ramp up.
Mm.
Well, Sherry, thank you very, very much. This has been fascinating. We might have to have you and Tom back on Medicare
Great. We can
pricing.
debate.
Okay.
Okay.
That would be that would be a lot of fun to have that. Really appreciate your time, and you, Sherry, I know came over from another meeting to join us here. So really appreciate it, and thank you very much.
All right. Thank you for having me. Take care.
Thanks, Sherry.
So we are going to go ahead and move into our discussion section, a couple of articles we have for discussion today. The first article, which comes from Axios, is on digital startups are running out of cash, and fire sales are expected. And, this is not terribly surprising. It's been a relatively tough period. The market took off very easy for a lot of companies to get cash. But I think the numbers are, really stunning. You went from a high of, I think, 29.2 billion in 2021 to only 8.6 billion raised through the third quarter of 2023. And the average deal size went from almost 40 million to 23.5 million. So firms are struggling. Included in that is, you do see, a lot of the companies they sell to are struggling a bit, particularly on the, hospital provider side. And, companies are trying to figure out how do they stretch that cash. And I do think this is going to be a year, and we've had this before, of consolidation. And it'll be interesting because I think there will be some consolidation into the providers, but I do think there'll be some consolidation among some of the startups themselves. And you've seen a little bit of it with Hatco, which is the General Catalyst company buying Summa Health, and looking to make some more acquisitions. What are your thoughts on this, David?
Well, a couple things. First of all, I messed up. It wasn't from Axios. It's from Shifted.
Okay.
That's how good I am at co-hosting and producing. But
well, you are very good at co-hosting and producing. You're just you got a lot coming at you at once, so we will give you a pass on that.
Well, the Sherry conversation was fascinating, and I felt like I could have done like a week of prep for that. But on this one, I do have a little more experience, and I think in the larger startup space and then in healthcare, we've seen a lot of consolidation already. And I'm very interested. I've been asking myself all of 2023, why aren't we seeing more big acquisitions? Because a lot of these startups are as cheap as they're going to be right now. They're below previous valuations, and they're still providing a lot of the same value. And I think it's a great opportunity. And this article kind of speaks to that. One of the things you and I were talking about in the pre-show that I'd love for you to kind of expand on is what is specifically different about the change in the healthcare space. So, we had a long period of super low interest rates, and we know that's a factor in this. But what is specific to healthcare that is really, creating this prediction?
Well, I think a couple things. One is we just talked about was the fact that you've got a lot of the hospitals themselves and even some of the physicians under a lot of pressure. Margins are very tight, particularly, you look at what's going on with workforce. That's the single largest item of any hospital's expense chain. And that's gone up dramatically. It's starting to level off. The use of travel nurses and others has come down a little bit. You've also had the impact of, what happened on the supply chain. That too, it's their second largest expense. That's come down a bit. And, so that's helped. Then on the other side, you've got, employers who are buyers of a lot of these services through the payers. So you've got a couple of things have happened there. Employers have been overwhelmed by the number of point solutions. So I think the employers are starting to, trying to figure out how do we consolidate some of these point solutions. And the other, part of that is, looking at the areas which have been really costly. And you've also seen in the employer space a number of employers. There have been a large amount of delayed or deferred care during COVID, which you referenced, a lot of preventive care, particularly in oncology. So you're starting to see people with, much later stage disease, particularly in cancer. And I've heard of a number of places which have not one or two people, but more than that, hit the stop loss. And for those who don't know, stop loss is reinsurance that a employer will buy so that they have to, a self-insured employer will buy. So they have to provide coverage up to a certain level, which is usually fairly high. But then another reinsurance company will provide after that. So hitting that means you may have a $100,000 claim, $200,000 claim, or multiple claims of that nature. So I think that's hurt. And then, I do think, some of the payers have spent a lot of money on innovation, and they're starting to try to figure out where, where it's really paying off. And so you're starting to see more people, really be more selective on, services that instead of just generating a lot of ROI are really creating true sustainable businesses.
Mm-hmm. Yeah, that's interesting. I know we need to move on, but I guess one thing that this article highlights is that they think they're going to see more payer specific acquisitions of these startups. Are there examples of payers acquiring healthcare startups and then selling those services directly to health systems, or would it all be for their own consumption with their subscriber base? How are they thinking about what are the precedents there?
Well, I think there are. I can't honestly think of any off the top of my head, maybe time pressure, but I do think what's interesting is more on the other side, kind of what Hatco is doing with Sumo, where Hatco is saying, okay, we're actually going to look at even maybe creating our own EMR. So we're going to, and I would assume as they're looking to do some of this, they're going to pick and choose different pieces of the health tech ecosystem to create these different things that they think are going to make the provider organization they buy more efficient and more effective. So I think that's going to bear watching.
Awesome. Exciting. It should be an exciting year.
Yeah, I definitely do think exciting year, and I do think there'll be a lot of consolidation, and frankly, some health techs going out of business, unfortunately.
Oh, there will definitely, yes, we will definitely see that. Yeah. Well, do you want to move on?
Sure. So the next article is on new limits. This one actually is from Axios.
Correct.
And new limits on prior authorization hailed as a good first step. David, this kind of falls right into your wheelhouse, so I'll let you go ahead and comment first.
Well, I don't know if it's my wheelhouse per se, but it sounds like the government is trying to incentivize speed with prior authorization in an effort to kind of alleviate some of the frustration that patients and clinicians have. And from what I read in this article, the overview, it really is focused on speed. So there's I think it's a 72-hour requirement on certain treatments and things like that. And then the article alluded to that something I'm not familiar with, that the government, is generally just applying more pressure on the concept of prior authorization. So what I guess like the speed thing is interesting to me, but bigger picture, I'm curious if this process, like how it's going to evolve. And, the frustration that I've often heard from, just anecdotally from, friends and colleagues is that, they aren't approved in the prior authorization, and there wasn't really anything that spoke to that per se. And I know that, that's one of the hopes of artificial intelligence to kind of help streamline some of these processes. But so I think it's good that that there's some federal pressure on the process, and it sounds like payers are already adapting. But bigger picture, I'm kind of left with like, well, what is the qualitative, experience there? Where can we impact it to really serve the patient beyond just speed?
Yeah, well, I do think that will help, and I do think the speed is important, and I think the other thing that the law requires is it does require the companies to be more transparent with their reasons for denials and their denial rates, and I think that will be very interesting. So as I mentioned on the earlier session with Sherry, I actually do teach at NYU, and I teach a course called Advanced Healthcare Payment Systems, and we talked about this in our last class. And it costs, I think, hospitals about 5% of revenues for denials. And this was 2017 data from Change. And it cost each denial to get it finally approved cost about $118. So I think that will help in the sense of, hopefully making things less costly if they're more transparent, if they're more rapid. The two things that I think right now is this only applies to Medicare, Medicaid. It doesn't apply to employer-sponsored health insurance, which is roughly half. And there's no talk about what the penalties will be. So I'd like to see how that evolves. But I do think as you start to get it more transparent and as it becomes quicker, hopefully it will make the process where there are maybe legitimate things are missing, numbers, claims, whatever, make that quicker and hopefully make it a better experience for the patients.
Yeah, the cost savings is really interesting there too. It's interesting when they're referencing that the cost of it. Is it completely administrative? Is that where those numbers come from?
As far as I understand it, it is the amount of administrative cost and effort to the back and forth between filing the claim, having it, and this isn't all prior auth. This is denials, but prior auth is obviously involved in denials. This is total cost of denials and claims adjudication and everything. And I think something like 68% of denials eventually get approved. So that is this is part of it. And prior auth is a very large part of what's going on is putting these into the funnel. And I'm well aware of in particular specialties, pediatric surgery, one doctor who has a very large binder of all of prior auth stuff, which prior to this point had to be faxed in, faxed back. Very, very labor intensive, very, very costly.
Yeah, I have I'm sure many people that aren't super young have experience in this space, and mine was the process sort of broke me down. Right, I didn't get prior auth on a procedure. I tried to pursue education or getting them to change it, and I sort of got worn down through the process, and I just ended up paying for the procedure out of pocket. So it cost them something for me to debate it with them, and then I still paid for it. So
yeah, no, they have it's a very it's a chess match, unfortunately, on both sides. I do think that the payers have got a lot invested here. Hopefully this will payers spend a lot of money here too, so hopefully it can make it more efficient for the payers as well as the providers.
It makes me think that we need a your co-hosts always play the patient advocate, Jeff. That's a theme of Diagnosing Health Tech, but their AI on and other kinds of efficiency tools on the prior auth process. It reminds me of like the sort of bill cancellation and subscription cancellation and tools that consumers have now, where you can sign up for a website and they'll handle canceling every bill for you or something. Patients would really be rewarded by having some tools to navigate some of these tedious processes on the consumer side.
There are people who are working on some things like this, and the question of, will the, and, obviously I'm sure people have opinions as to whether the government will get this straightened out before some of those consumer tools come into place. But there are definitely people who are working on this from both the consumer and the provider point of view.
Oh, that's good to know. That's awesome. Next story.
Go ahead. Move on to the last one. So the last one is from our friends at Rock Health, and it's the digital health turn of 2024, tracking developments along the innovation maturity curve. And since we're coming up on the top of the hour, I'm just going to hit these very quickly. They are saying that food and medicine is on the nascent part of the curve, and this is moving from diabetes to broader forms of care, to cancer and mental health. And the important thing is to watch the funding. National Institutes of Health just made almost $2 billion available, and to really watch play people like Kroger and Walmart. Digital obesity care, which we just talked about a bit with Sherry. Publications regarding the digital delivery of these obesity drugs are something up like 85%. They are saying this is also nascent, which I would agree, and those publications are up about 85% over the last 2 years. The thing I would say is, the article mentions watching the access, the availability of the drugs, as the manufacturers are having the ability to produce them. And I think the employers and others will put up guardrails around them. And then last but not least, everyone's favorite topic lately is artificial intelligence in healthcare. AI venture funding was $2.3 billion. There are 101 deals, and this was 2023. I'm sorry, that's $23 billion. And that was through Q3 of 2023. The FDA expected to approve 30% more deals in 2024. And they're saying this is developing. And I do think, as we're talking about with Sherry, you're going to see a lot more action here, particularly on the front end for providers. Your thoughts, David?
Well, I think it's an incredible report, and I love the things that you chose to highlight, because to me, those are also the most exciting things, both as a patient and someone working in the industry. I think, I'm a big fan of maturity curves. It's something we talk a lot about at Redox. And the idea that food as medicine could be something that's taken seriously across the industry, that could have really positive systemic effects across our American society. I think that the GLP-1s are very interesting, and you've done a great job of kind of consistently talking about them. And it was interesting to hear Sherry kind of talking about the larger economic consequences there, and how that will potentially work out. And I think, aside from just the positive long-term health impacts of GLP-1s, it's so interesting because they're sort of part of that unofficial category of drugs that appeal to vanity.
Yeah.
And so there's just like a lot of patient motivation in that space. And I imagine that it will quickly move from nascent to, something that's broadly known because of that. And then AI, what an incredible force of change. And I think we all get sick of sort of talking about it in generalities, but then we see some innovation month after month in the space, and it's always just so impressive. So, similarly, I think everyone is motivated to see where this technology takes us. Everybody should check out this report in the space, because I think it's a great overview.
Yeah, I do. And with that, I will start to wrap us up. But thank you very much for joining us. Not to be left out on the AI parade, I do ask you to please check out our blog, and please do sign up for our blog. This week's blog is using AI in cardiology to soothe the heart. You can check out the QR code there. Please do follow us on LinkedIn and on Twitter at HealthcarePen. Feel free to reach out to me on LinkedIn. We are the Healthcare Strategy Bullpen. We like you to think of us as the Rosetta Stone that helps translate the language and culture of technology into healthcare and vice versa, to help you adapt and deploy your healthcare tech to improve the lives of patients. Once again, I'd like to thank you for joining us. And next week we have Jenny Shulkin, who is the CEO of Override Health. We'll talk about their virtual care platform for chronic pain. And with that, I will turn it back over to David.
Yeah, I can't wait to check out your blog and to hear from Jenny next week. Redox is also sponsored by, Diagnosing Health Tech is also sponsored by Redox. We are the healthcare data interoperability specialists powering many of the new cloud innovation that the industry is going after. Diagnosing Health Tech, you can subscribe on your favorite podcast platform, Spotify, Apple Podcasts. We're on YouTube, and we're broadcast live every week on Thursdays at 11 a.m. on LinkedIn, YouTube, and on the redox.com website. Thank you so much, audience. And Jeff, thank you so much. It was a great show. Loved hearing from Sherry.
Thank you, David. Thank you for popping in, and appreciate it. And look forward to having everybody next week.
Yep. See you next week.